I was often embarrassed by the way people would react to my veins. I always covered my legs.
I was certainly self-conscious, being out in public with shorts at a public event where I'm walking around with friends.
If you experience discomfort, swelling, and varicose veins in your legs or ankles, you may be suffering from superficial venous reflux disease. Approximately 25 million people in the United States suffer from this condition. Varicose veins are caused by damaged valves, which result in backward flow of blood in your legs, a condition known as venous reflux. This can cause blood to pool in your legs and lead to symptoms such as pain, swelling, and varicose veins.
What it's like having varicose veins at the young age that I had them is like being an old lady before your time. You get tired easily, you have a lot of pain, your range of motion is somewhat limited. My legs were swollen.
The symptoms I experienced were pain in my right thigh, some muscle cramping, and bulging veins in my shin and calf. It was really bad.
Superficial venous reflux disease can be progressive. Symptoms may worsen over time if left untreated. By seeking treatment, you have taken the first step toward recovery from these painful and unsightly problems. Traditional vein stripping surgery has been the only option available to treat venous reflux, an underlying cause of varicose veins. Vein stripping includes incisions at the groin and calf. A stripper tool is threaded through the diseased vein, and the vein is then pulled out of the leg. This can result in pain and bruising for the patient during the 2 to 4 week convalescence. Now patients can be treated with the closure procedure, a minimally invasive alternative to vein stripping surgery. Closure utilizes radio frequency energy to heat and seal the vein shut. In one report, 98% of patients surveyed who have undergone the closure procedure are willing to recommend it to a friend or family member. Recovery time is very short. Most patients return to normal activities typically within a day. If your physician feels that you are a candidate for the closure procedure, here is what the preparation for the procedure will be. Using ultrasound to scan your leg, your physician will determine where superficial venous reflux is present and map your vein. The closure procedure is performed on an outpatient basis. Using ultrasound, your physician will position the closure catheter into the diseased vein through a small opening in the skin. The catheter delivers radio frequency, or RF energy, to the vein wall. As the RF energy is provided and the catheter is withdrawn, the vein wall is heated, causing the collagen in the vein wall to shrink and the vein to close. The closed vein is left in place and over time is reabsorbed by the body. Once the diseased vein is closed, the blood is rerouted to normal, healthy veins.
My experience with the closure procedure was exactly like my physicians told me it would be, every step of the way.
The closure procedure was very comfortable for me.
There was no pain, no throbbing, no numbness, none of the things that they said might happen. Nothing. I felt perfectly fine. I mean, I was ready to get out of bed and walk out of there.
Following the procedure, a simple bandage is placed over the insertion site. To aid healing, your doctor may also wrap your leg or provide compression stockings for a short period of time. Your doctor may encourage you to walk, avoid long periods of sitting or standing, and refrain from strenuous activities for a while. The closure procedure allows you to get back to normal routine activities, typically within a day, with minimal to no swelling, bruising, or scarring.
The fact is, I could walk around. That was the amazing thing to me. 2 hours after my procedure was performed, I walked up 2 flights of stairs under my own power, walked around, got myself something to drink, watched a couple movies.
The day after the closure procedure, I was up and hiking on the mountain. Now, I had some discomfort from leaping right into a difficult, steep mountain hike, but not enough to complain about. And so I'd really have to say that I was able to resume normal activities within 24 hours of the procedure.
In a comparative trial, results were in favor of the closure procedure as compared to vein stripping surgery. Key findings indicate that patients who underwent the closure procedure experienced significantly less post-operative pain and bruising and returned to work more than a week earlier than vein stripping patients. The closure procedure has proven to be highly effective, with more than 90% of veins treated remaining reflux-free 2 years after treatment. Patients report rapid and pronounced relief of venous reflux symptoms in legs treated with the closure system.
I feel fantastic. There really isn't anything that I can't do.
The cosmetic effects were 100% improved. The bulging in my legs that I'd seen that was thick as my finger, gone. Haven't seen it since.
I have to admit that I get compliments on the way that my legs look now. That's something I never thought would happen.
Physicians may recommend other treatments, including phlebectomy, sclerotherapy, or surface laser treatments to address visible spider and varicose veins. Phlebectomy is often used to treat medium to large-size varicose veins. Using specialized instruments that resemble crochet hooks, your physician will make a series of tiny incisions and remove noticeable diseased veins. To treat tiny purple or red veins, often referred to as spider veins, your physician may perform sclerotherapy. Using a series of injections, your physician will deliver a chemical solution within the vein. The solution damages the inside of the vein wall, causing them to close. Multiple treatments of sclerotherapy are usually needed to achieve good cosmetic results. Following phlebectomy and sclerotherapy, your physician may advise you to wear compression stockings. The closure procedure has been successful for treating appropriate patients with superficial venous reflux. Follow up with your physician to determine the best treatment for your condition.
Hi, my name is Dave Jansen, and I'm pleased to welcome you to Fox Valley Plastic Surgery and to specifically talk with you today about veins and vein treatment. Dr. Dubeck and I are both plastic surgeons, but as we started our practice, we really decided we'd do only plastic surgery in our practice. And so, having done a lot of varicose vein surgery in our residencies, neither of us wanted to deal with the larger varicose vein operations that involve a lot of pain and swelling and problems long term. And so plastic surgeons in general don't do varicose vein surgery. We, however, found that we were treating a lot of patients for spider veins and then little larger spider veins and small varicose veins in their lower legs. And a new technology came about that allowed us to really look at varicose veins in a different light and treat the larger varicose veins and even the whole leg veins, so that now we've developed a program of really what we consider total vein care for our practice. Total vein care involves dealing with the larger veins of the legs and dealing with even the very large veins in the thighs and calves and what are considered varicose veins rather than just spider veins. This means that we're dealing now, instead of dealing with patients on a one-to-one or cosmetic basis, we're dealing with patients on a insurance-covered basis because we're dealing with larger and therefore symptomatic or medically indicated procedures. Most of the procedures I'll talk about today, until we get to what we consider cleanup issues, are procedures that are covered by insurance. Every single one of them has told me after they've had the first leg done how much better their leg feels, how much less heavy, how much pain, even stinging that people have in their veins before this goes away having had this procedure performed. So I'm becoming very much a big believer in doing this procedure, and it really is helping a lot of people. The reason people come in may be unrelated completely to the way their legs look. A lot of people are coming to us now saying, my legs are just heavy. They are painful. And they're really ending up with a great result through this venous closure technique. The old way of doing this, again, was by basically stripping the vein by putting a wire up the length of the leg and pulling the vein back, basically pulling it inside out and ripping it out. That was a procedure done in an operating room under a general anesthesia, with lots of long-term issues and pain and problems and bruising and time off of work. This procedure basically shrink wraps the vein while it's sitting inside the leg. We put a wire up the length of the leg and are able to close the vein. By closing it, I mean shrink wrapping it from the inside with heat. We do that with the leg numb, we do it in the office, we do it under local anesthesia with a little bit of oral sedation. Patients come to us with basically 3 or 4 different issues that lend us to believe that they really have significant problems with their legs. The first is a family history. A lot of patients come to us saying, my mother had this, my sister had this, my brother had it, my father had it, and the reason that their legs are heavy or painful probably is mostly related to their genetics in that situation. There are a couple of things that create the insufficient varicose vein. And when I say the insufficient varicose vein, most people remember from high school biology that the arteries are to take the blood out to the extremities and the veins are supposed to bring the blood back. Well, when the vein blood reverses and flows back down the leg instead of back up towards the heart, it's considered an insufficient vein. And so people get that for a couple of reasons, one of which is just their veins are loose or lax, and that can be a result of their genetics. 2 other significant reasons come about, especially in women and especially through pregnancy. Estrogen itself is a relaxing hormone which makes veins relax. Not only estrogen, but even some of the hormones produced by the placenta when you're pregnant also significantly relax almost all soft tissue structures like they do the pelvis to allow a baby to come out. That makes the vein relax too, and then the veins become looser. Not to mention the basketball that women carry around in their pelvis for a couple months that really presses on those veins. All those things add up to help make the veins further incompetent. And so those histories and the history of standing on your legs for a long time, and basically we live in a world with gravity, and the weight eventually over time results in the veins starting to fail. And so as people fail, their veins dilate, their legs get heavier, they start to get, it may be the first thing they see, they start to get spider veins in their ankles, and then they get bigger veins in their calves, and then big veins in the thigh. It's really, I like to compare it to a kind of an interstate highway backing up. If the interstate backs up, the on-roads and entry ramps to the interstate back up, and if that backs up, all the roads that are trying to get on the interstate back up as well. And that's kind of how the leg works. The interstate getting out of your leg is one of 2 major vein systems. The big one is the femoral vein, and the smaller one that is less important and in your skin is the saphenous vein. And that is really the vein that we are treating through vein closure. So our goal is to reverse the problems that's caused by the vein flow going backwards down your saphenous vein. There's a detour that the vein blood can take out of your leg. It can go from your saphenous system into your deep femoral system through what are known as perforators. And so your body can find a way for that blood to get out of your leg even if your saphenous vein has been closed from the inside. Our goal will be to talk with you and talk you through this and hopefully have you understand this process. In order for this to be a covered procedure for most people, some criteria to get this done must be met. Your insurance company will be paying for this, but there are hoops and loops that need to be dealt with in order to get this done. The first of that is they want to know that you've tried conservative measures in order to get this done. They will ask, and we will ask you on an encounter sheet yet today, whether you take any medication for that. And by medication, they don't mean Vicodin. They mean, do you take Motrin? Do you take Anacin? Do you take Tylenol because you have leg aches and pains? If you think that they don't count for your insurance company, they certainly do count. So we want you to list those medications on your encounter form. Another strong criteria for them is whether you've worn supportive hose. Now this can be something that's over the counter, but most insurance companies will ask that you have worn supportive hose for 4 months. If you've never worn them, you need to be honest on your insurance form and with us, and we will write a prescription for medical grade support hose. Some insurance companies will require that you wear those for 4 months every day and that you attest to that in order for them to cover this procedure. Really, I don't believe that once you have these that the support hose are going to make them go away, but it is a hoop and a loop you have to jump through and around in order to get this procedure covered. We will look at your legs today and probably take pictures of your legs, which will go towards a letter to your insurance carrier, but the gold standard to determine whether your legs are flowing backwards is an ultrasound. But it is a test that is done here in our office without the need for local anesthesia. It is a painless test, and it is done where somebody puts a probe over your skin and listens to your blood vessels, and with some squeezing of your calf and of your leg and having you hold your breath and doing a couple maneuvers will determine whether your veins flow backwards when they need to flow forwards. And if that ultrasound is positive, we will then use that test and information and the results of that test to submit a letter to your insurance. We will also only do one leg at a time. The reason for that is if you have a problem in one leg, we only want it to be a problem in one leg. And so we will only do one leg at a time. We'll say for the purpose of this video that you've cleared the prior authorization process to have this procedure performed. You must bring the support hose with you when we do the procedure. These are specific to you and will be done as a prescription. Actually, the prescription, without trying to be proprietary and with no personal interest in Morton Pharmacy at Mercy Oakwood handles the support hose prescription we'll be giving you today. Most other people have a hard time finding the stockings if they don't go there. We need you to bring those support hose in when we do the procedure because those are the ones that already fit you. You will then come to our office with a reasonably empty stomach. The reason we want you to have a reasonably empty stomach is we want to give you some medicine that will sedate you, and we're going to give it to you by mouth. If you come here with a full stomach and we give you medicine by mouth and it sits in food, you will not be sedated for this procedure. If you have significant narcotic issues, meaning we will be giving you a narcotic pill, it's the only pill of narcotic that we will give you for this procedure is an hour before the procedure. But if your stomach is very sensitive to that, we won't give you that. We'd give you an alternative medicine for prevention of pain through the procedure. You will come here then the day of the procedure, and our ultrasound tech will do a mapping procedure. Sue, our ultrasound tech, will spend about a half an hour doing the mapping. She'll show us by drawing on your outer skin where the vein is, and we can find it with the ultrasound, but we like to have it traced out on your skin on the outside to determine where we are going to close the vessel. And we close the vessel from the groin down to as far as we can get the catheter to comfortably fit. This catheter is about the size of a Bic pen lead, or the inside of a Bic pen, and so it doesn't fit in all veins, but it fits in almost all varicose or larger veins. We will then take you to our procedure room where under this local anesthesia, oral anesthesia by the pain pill in a Valium and an antibiotic taken orally, we will then do the vein closure procedure. The vein closure takes about a half an hour to do. We first put a needle into the vein and then put the catheter up through a needle. We then numb all the way around the vein the whole length of the leg. That involves 4 or 5 needle sticks. And that's really the hardest part of this whole procedure, is a couple of needle sticks to numb the area, where we will then put actually a larger needle through to further numb all the way around your vein. We numb all the way around the vein, but people don't describe that as pain. They just feel pressure around the vein, and it's usually, it's done under ultrasound guidance, done so that people really don't complain about that being painful at all. We then do the vein closure, and that involves turning on a device which heats up the wire that's inside of that vein. Now, it doesn't heat the whole vein at the same time. It heats a section that's about 2 inches long for 20 seconds. And then we back the catheter out by 2 inches every 20 seconds and heat the vein and basically close it by shrink wrapping it from the inside as we pull the catheter out. To this point in time, we've had a 100% success rate by doing that procedure without creating a clot into the deeper system. We don't know how our statistics will hold up long term, but long term in big studies, this should be something that lasts for more than 99% of people long term. And by long term, I mean it probably shouldn't reoccur. The varicose vein or the greater saphenous vein that we treat should probably be gone forever. The biggest risk from this procedure would be a clot that would go up the vein higher than we anticipated. And that is why doing this procedure with an experienced registered vascular ultrasound tech, which we have at all of these procedures, is important. And the RVT tells us where we are so that we stay 1 inch below the area, the highest area where we could treat, and that avoids us getting in trouble with over-treating. We remove the catheter, and at that point in time, after a period of about 3 minutes total, for the actual closure, that part of the procedure is done. Once we've given you a Valium and a pain pill, you have to have somebody else drive you home. If you come here the day of the procedure and your ride can't come, we can't give you any of the medicine that sedates you and relaxes you or relieves your pain through this procedure. And so it's strongly recommended that you make certain you have a ride for the day of this procedure, not necessarily a ride here, but certainly a ride home. We are left then to do one of 2 procedures. The first of those is to do stab phlebectomy. It's called micro stab phlebectomy because we make a very short incision, 1/4 of an inch. It would be long probably for this procedure, but about a 1/4 of an inch incision, and we will fish out some of the larger varicose veins that we're not able to get to with the closure catheter. And that will improve the appearance of your legs, but it also helps with the achiness and pain, and for some people with vein ulcers which occur on their legs. We do anywhere from 1 to 30 of those in one setting, and it takes about 1 to 3 minutes each vein to remove those. It's fairly simple. They're 1-stitch closures with removable stitches, and people do very well with those. There's a little scar from each of those, but they're typically much better looking than the varicose veins. As long as people avoid sun to the scar in the first year, and I don't mean you can't go out in the sun, it means your scar needs to be protected with sunblock for the first year after the procedure. Most people should end up having a wonderful appearance to their legs. And even though that's not the core reason for doing the procedure, we like to believe we have a plastic surgeon's approach to dealing with this medical process. Following the stab phlebectomies, if there is a large vein called a perforator that is incompetent, in other words, the deep system is running backwards, we will do a second procedure called an RF ablation. Most people won't have that done, and so we will talk about that at a different time. As an alternative to vein closure, which is putting a wire into the vein and using a radiofrequency energy to heat or get rid of the vein, there is another option or alternative, and that is to use the Cyton Joule laser. When we use the laser, we actually place a fiber optic lighted device inside the leg. It is smaller than a pencil lead, and it is threaded up the inside of the vein. When the laser is turned on, the light heats the vein wall and closes it from the inside. In some situations, the laser may be preferable to the venous closure. We let your leg determine what we think we should do based on how tortuous it is, what size your vein is, and how we feel we can thread it. And so we'll make a decision based on what we feel is the best treatment for you on the day of your procedure, to do the venous closure procedure or the endovascular laser ablation. For you, it won't really matter because the treatment will seem to be exactly the same. For us, the energy is slightly different, and we have our reasons for using one versus the other. We're happy to explain that reason to you before we do this procedure. At the completion of venous treatment, there may be other procedures available to you. There are times when people don't like the other veins in their legs. At that point in time, we have some alternatives to clean up the small spider veins or larger collections of veins that men and women tend to have in their lower legs. The three treatments we start with include sclerotherapy. We don't use salt water, although many people do. It burns and doesn't seem to work very well. For the superficial small veins, we use a medicine called glycerin. Glycerin is very safe. It doesn't cause brown staining or marking and works very well to sclerose small to medium-sized veins and legs. Larger veins need a bit more noxious medicine, and that can cause some problems with brown staining. And although those large veins eventually form clots once we sclerose them, we do need to use a fairly aggressive medicine to treat the large veins. Sometimes we can't even see those large veins well with a naked eye, and we have to use an ultrasound. When we use an ultrasound to do sclerotherapy, that is called echosclerotherapy. Occasionally, insurance will cover that. Frequently, it will not. The second treatment we offer is called vein wave. That's a microscopic version of the radiofrequency ablation we do with the big vein. It's with a very small needle placed inside the spider vein. We basically turn the energy on and use the radio wave to get rid of the varicosities and get rid of the spider veins. Frequently, there is a vascular blush or something that almost looks like a reddish area where it isn't specifically a vein, but a reddish area in the skin. We have lasers that can treat that red look. We'll use our VersaPulse or one of our other newer Jewel lasers to treat those. Insurance may or may not cover some of these procedures. We do, however, offer the complete spectrum of total vein care here. We can take care of any vein problems your legs may have. Following the procedure, we will use a small piece of gauze with antibiotic ointment over each of the sites where we go through the skin and wrap you up with support hose. Our goal is for you to wear the support hose almost continuously. In other words, except for when you're in a shower, and you can take a shower the day after surgery and take all the bandages off, and then you don't need any further band-aids or bandages. You put the support hose back on. We want it on essentially continuously for 3 weeks. The biggest problem you could expect to have early after the surgery is some bleeding from where the stab phlebectomies are performed. That happens in about 10% of people where at one site where we've taken out a piece of a vein, it starts to bleed. Usually 10 minutes of just putting direct pressure on there with your finger and just holding it and sitting still and having your legs up solves that. We've not had anybody have to go to an emergency room or be treated with that outside of just telling them to put pressure on that. And so if you have a bleed, that is our recommendation. The support hose, if it's not worn, could result in some added bruising and problems for you with added pain. The other issue that's real significant is we don't want people doing a lot of long-term sitting after this procedure. So we actually encourage you to get out, go to work the next day, and be active. If your job involves just sitting at a chair, we want you to get up and move around at least once an hour for a couple minutes so you're actually doing some significant walking. If you're a marathon runner or you need to exercise every day, we ask that you just chill out a little bit on that and just reduce the amount of activity you do so you're not bouncing so much. Bouncing can cause bleeding and increase bruising, and so we'd really like you to have about 4 days before you're back to running, for instance on a treadmill or outdoors. We'd ask you to get on an elliptical or walk on a treadmill so that you're not bouncing so much. After 4 days, you're clear to do full bore activity in your stockings. After 3 weeks, you can be out of the stockings and really at full bore regular activity. The only other activity I'd talk about is flying, as there is such a thing as economy class syndrome where people are found to have deep vein thrombosis or clots in their legs as a result of sitting in a cramped airline space at altitude. If you are going to be flying, you need to walk frequently in an airplane. So we have had people do this procedure and go flying, but we tell them they need to walk frequently on the airplane, get up and down, and be walking while they're flying. Other than that, our patients have done very well, At 3 days after this procedure is performed, we have them come back and make certain that the vein is clotted all the way up the length of the saphenous vein. And at that point in time, then we typically will just see them 1 month later and make certain everything has gone well. Our experience has been that people are very happy with this, and we've had a high likelihood that insurance will cover this procedure. Thank you.